Hey guys, this is Eduardo. Finally decided to do the challenge, so I decided I would be tackling the Sustainable Development Goal number 3, more specifically tuberculosis. So basically, with the data I've gathered, I basically analyzed the problem of tuberculosis in underdeveloped nations, and at the end, I'll provide some possible solutions and hope that we can get on track to ensuring healthy lives and promoting well-being for all at all ages. So let's get started. So just as a background, tuberculosis, or I'll be referring it to TB in some occasions, is a slow-growing bacteria that affects areas with lots of blood and oxygen. It's contagious and it spreads through the air. So as you can imagine, this can be very prominent in the lungs, right? Because there's a lot of blood, there's a lot of oxygen, and it's where the air flows, right? Also, this bacteria is very mild, so there's a possibility that people don't even know they have it, which can be a problem, and which is one of the issues that are present nowadays, since it's very hard to detect at some points. Some of the ways that you can tell if somebody has a non-mild variant of TB is through blood cough, tiredness, fever, but usually the symptoms appear when there's a more severe case of TB. The way that you know that you have TB is you can test for bacteria in mucus if it's a pulmonary, which I'll expand on later, and or you could do tests in body tissue for this bacteria. Um, then for the possible treatments, you can have first line and second line drug treatments. Usually first line treatments are the ones that you do in the beginning, and second line the ones that you do in case the first line treatments don't work, but I'll also expand on these later once I go through the data that these entail. Lastly, I want to point out that TB is not only a medical problem, but it's a social problem because of the fact that uh, TB has a great impact on development and not in a positive way. So it's very hard to push for development when you have infectious diseases and bacteria such as TB that are causing a lot of people to die in your country. So in terms of what data I used, so most of the data that I decided to use comes from the World Health Organization and the Global Fund. And then there's a few different sources of data from isolated academic studies. I'll list in the email that I'm supposed to send to you afterwards most of the sources that I used. But basically for TB, the data is very limited. For one thing, it's very hard for to find information for developed countries, just because TB is not much of an issue in these countries. And then for underdeveloped countries, it's an issue because usually they don't have the funds to actually go out and get this data. Apart from this, the data for TB is really lagging. It seems like health professionals in the near past thought that TB was under control, but most recently, TB has come again rising and has been one of the major health problems globally, especially in underdeveloped nations, and is also leading cause of death, especially in impoverished nations. The data that does exist, however, seems to be reliable enough, but there are some reasons why you would want to question it. Some of the data is inconsistent. So you find data from some countries you can't find data. Accuracy, some of the data sets, especially ones that I'm going to point out later in these underdeveloped sub-Saharan Africa countries, seem to lack accuracy because there's way too big of a gap for this data to actually be consistent. But in terms of getting the global picture of what's going on with TB in the world, I think it does a decent enough job for you to draw some conclusions. And like I mentioned before, these countries that actually need to get this data usually are limited in resources and therefore do not have programs established. in order to get these types of data sets, therefore making it very hard for health professionals to study what the real impact is. What I'll do in order to explain what is going on with TB and what some possible solutions might be is going to be to use the data that I found from these different data sets in order to back up the story of where TD is, how it is currently, what's going through it, some assumptions that we've had for TD over the past few years, and what some possible solutions are. So I'll talk about that later on in the presentation. So just to start off, we should ask ourselves, like, what problem should we be trying to solve in regards to TB? So realistically, we can't say that we're going to eradicate TB from one day to the next. Usually, uh, bacteria like these lie around for many, many decades until finally someday we get so close to eradicating it that we are able to do it. But TB, unfortunately, is not in that situation as of yet. And TB is, like I mentioned, a social problem too. So it is very necessary to have some type of government policy in regards to health for you to be able to get towards that step of eradicating it. So if we try to set a goal to what do we want TB to be in the first place as of right now. So in the short term, we should start implementing feasible solutions and policies to help gradually reduce TB. So that's a realistic goal that we can make now, because we can't really say at this point that we have to eradicate it. We have to work towards it, right? And again, this is a particularly important problem in impoverished nations because of the fact that it hinders development. So the question that I ask myself and that I'll be exploring is, what are these feasible courses of action and policy plans that can help us reach the goal that we stated beforehand? Okay. So, how do we identify the problem? So, basically, I'm going to explore this problem. I'm going to identify and explore this problem um, from the assumption and from the data that backs me up that there's less TB exposure in developed countries, but we do have some information from it. So just by using the status of being a developed or underdeveloped country, I can kind of normalize this in order to be able to portray a difference, right? So if I just show you underdeveloped nations, it might not seem as radical as it actually is, but I'm actually going to show you what developed nations are doing towards getting to this goal of eradicating TB in the near future. And this is also going to show you how TB and HIV, because TB and HIV go hand in hand, can be a product of poverty, right? So I am going to analyze various issues regarding TB and HIV in developed and underdeveloped countries, including exposure prevention, treatment, and complications from the TB bacteria. And I'm going to also take into account the status of every country and then do this analysis. So basically what I did is pooled a group of developed and underdeveloped countries, so two different groups, which are representative of the exposure of TB. So the group of underdeveloped nations is has very high exposure to TB and has had very strong repercussions from it. And then we have the sample from developed nations, which include Canada, the UK, the US, Australia, where, as we know, and because we live here, we know that TB is not as prominent as it is in other areas of the world. And then these results will suggest possible courses of action for us to take in the future. So we're starting at the point where I'm making the claim that TB is highly correlated with poverty. So for me, in order to back this up, I decided to run a little exponential regression, and you might know that this is not a causal relationship, but this exponential relationship between the GDP per capita in year 2018 and then the TB and HIV incidence rate are very highly correlated and negative exponential way. So what can I gather from this? That even though not causal, it's still statistically significant, and it shows that in a sense TB is very correlated. So high levels of TB are also more likely to be countries where there is a lower GDP per capita and vice versa. So you can see that this exponential function actually predicts pretty well why or how, like what are the consequences of low GDP in this case, which are high TB and HIV incidence. Again, not causal, but it's really cool to see that poverty does play a role in this relation. And then I also whipped up another regression, same exponential function in regards to health expenditure. So health expenditure is a little bit trickier because it is it has to do with a lot of efficiency. So if you take, for example, United States happens to have a low TB incidence rate, but it not necessarily means that it's because they have high health expenditure. Their system is actually very inefficient. So this one not as helpful, but it still shows that countries that tend to spend more uh, in health as part of their GDP tend to have a lower incidence of TB and HIV in their population. So once again, uh, not a strong relationship, but still something worth looking at. So basically, we have two types of TB. So pulmonary TB and extrapulmonary TB. So like I mentioned before, pulmonary TB is the most common one. It's an active infection in the lungs. And it's the most important because it's highly contagious due to its mode of transmission, which is through mucus. So saliva, boogers, stuff like that will be able to translate um, pulmonary TB. And then we have extrapulmonary TB, which only happens between 15 and 20% of the time. And it usually happens in older people and children, so it's not um, as prevalent in the society, but still something that it's worth looking at. So, why is TB a big issue in impoverished countries? Well, this is because of the living conditions and the working conditions. And what I mean by this, and it's backed up by the data that I'm showing you, and I'm going to show you in the next few slides. Due to the mode of transmission, the ideal places where TB is passed on is in crammed, poorly ventilated, overcrowded places, and these places just happen to be more prominent with lower income countries. So think about like sweatshops or factories for working conditions. Um, in developed countries, we don't have those same working conditions. There happens to be more open space. We have better living conditions. So therefore, this factor is very, very relevant to why um, impoverished countries suffer from TB more than the regular developed countries that we live in right now. I want to point out that TB is part of this thing that I like to call poverty cycle. TB and HIV are highly correlated. Why is that? Because HIV makes your immune system weaker, therefore TB will be people will be more prone to getting TB because of that weaker immune system. Uh, we know from studies that HIV positive people are more likely to have limited access to medical services, and they're also more likely to be discriminated, that be in the workforce or just in general. So if people don't have jobs and people don't have access to medical services, they're more likely to live in poverty and in poor conditions. Therefore, these are optimal conditions for TB to develop. So, like I mentioned before, there's two types of TB. There's the pulmonary, and then there's the extrapulmonary. And I just want to make a point, backed up by the data, that pulmonary, as you can see here, for the most part, is way more prominent than the extrapulmonary part. So you can see that for the top three, South Africa, Congo Democratic Republic, and Nigeria, these are way higher than the top three for the extrapulmonary, so Ethiopia, South Africa, and Congo again. Still, as a trend, what I want to point out from this is that you can see that all of these countries that are on the high spectrum, that be pulmonary or extrapulmonary TB, all of these are the underdeveloped sub-Saharan Africa countries. You can see that the US and the UK and Canada, Germany, all those other countries are bunched up here towards the bottom because of the fact that they have way less exposure to TB. So in terms of treatments, so I'm going to quickly review this, but first line treatment is the treatment, once again, that people take in their first incidence of TB. So most likely when first treated, people are going to take isoniazid and rifampin. That combination is the most popular one, yet all of those drugs listed in there are equally as helpful. Then second line treatment, there are fluoroquinolones and injectable anti-tuberculotic drugs. So these are usually used when people don't respond well to first-line treatment, or they fail to finish a first-line treatment and gain some type of resistance from it. So why do I point the treatments out? Well, because there are two main issues that arise, which I'm going to show with some graphs in the next few slides, which is that there are the multi-drug resistant TB, so MDR-TB, or we can see RR-MDR-TB, which is the rifampin resistant tuberculosis. This basically means that the type of TB that these people have is resistant to at least two of the most powerful first-line drugs. So the ones I mentioned in the slide before. And then we have the extensively drug-resistant TB, which is resistant to isoniazid and rifampin, which are the two most powerful ones. And then any fluoroquinolone, which is a second-line treatment, and then at least one of the three injectable second-line drugs. So as you can see, this can become a big problem, and it is a big problem because of how people are in these underdeveloped nations getting more and more resistance towards this. And then secondly, we have that, like I said before, HIV and TB go hand in hand. HIV weakens the immune system, therefore making TB something easier for these people to catch. But also I want to point out HIV and TB as a social problem. HIV is still a little bit of a taboo, so people with HIV are usually marginalized. They might be discriminated, they might be shamed, and these are all factors that influence into how much people have access to medical health services. So just out of shame, some people decide not to go, and it's a real issue trying to get these people to go out and get their proper health services in these countries. So this graph basically shows the rifampin multi-drug resistance TB by year in the developed nations. So I just want to show this in order to basically set up kind of like a baseline so that we can look at the underdeveloped nations. So if we look at this, we see like the highest numbers here are in the 100s, 251. These are the highest numbers for the developed nations. But then if we go to the cases in sub-Saharan Africa, we see that we have a little bit of a discrepancy. So first, let's take a look at these lower numbers. They're still very high. In Uganda, we can see Mozambique and Zimbabwe. Like, these numbers below are still higher than the numbers that we saw in the developed nations. And I want to point out that here's when we come to some of the inconsistencies with the data that I was looking at before. South Africa is one of the countries that actually spends some of the most money in the region in health services, and for some reason they actually have very higher numbers than the counterparts from sub-Saharan Africa. So this actually makes me believe that basically South Africa has more access to actually identifying who the people are that have TB, while these other countries actually don't even have the resources to identify who has HIV and who has TB, so that they can be able to treat them in the same way that developed nations can do. So I think that was interesting, and I thought I should point it out. So once again, TB and HIV are a medical and a social problem. And then we can see that there is basically no discrimination in terms of the relation between TB and HIV. So we can see here that this is TB patients with known HIV status over the years. And you can see that it's very interesting to see that regardless of where this country is, if it's underdeveloped or developed, we can see that over the years, TB patients have been more and more likely to be HIV positive. So once again, this shows the importance of actually knowing who the people who have HIV and who are exposed to TB are, because people with HIV are very, very likely to contract TB if they're exposed to it. So once again, just to review for the next few slides, there's the first line treatment, which is the treatment that people receive when they're first exposed. And then we have the second line treatment when some of the first line treatment doesn't work. So I want to point out basically separated in groups. This is the developed nations group, and then this is the underdeveloped nations group. So just as a side note, some of these graphs have some countries and some don't. This is because of the inconsistencies in the data that I was talking before. But regardless, we can see that developed nations tend to have a very, very high percentage of the identified cases covered. So they usually, if they know that somebody has TB, they will act on it, while this is where it changed in underdeveloped nations, probably due to funding or some other type of inconsistency and non-efficiency. They might know that some people have TB, but they're not able to track them down and treat them properly. So this once again shows that regardless of whether a country is developed or underdeveloped, we can see that if TB is treated, there is usually a high rate of success when it is treated. So you can see here that for the most part is between 80 and 90%, with the exception of surprisingly Germany, which is below that. And you can see that this doesn't really follow the logic, but you can see that from this graph you can tell that people who have TB and are treated usually go to get better. This is where we get some interesting results and some finally some backlash from our shaky data. So when you see here when these values go to 0 or not is because for some reason data wasn't recorded in those years, so that kind of gives us an issue. But if we try to isolate, or for the countries that we do have data, we can see that HIV is a factor which causes the treatment to be a little bit less effective. So you see on average, this is between 70 and 85%, so a little less likely for people to get better with treatment, but usually it's still effective. And when we see multi-drug resistant TB, we see that this is where it gets very complicated, because it seems like our treatments are not really effective, or we don't know if they're going to be effective or not, regardless of which country you're trying to do them. If there's a multi-drug resistant TB virus or bacteria out there, it's very hard to know what results we're going to get at the end of the day. The good thing is, though, that with this limited data that I was able to get from underdeveloped nations between 2017 and 2018, that the African countries are actually stepping it up in terms of getting the MDR cases in second line treatment that need to do so. We run into another issue here where we see that this is the relapses. Usually this is a big issue because of the fact that TB tends to require a long process of medication, usually more than 6 months, and there needs to be a follow-up. So what happens is that if there's not enough access to treatment, or there's a lack of follow-up, the first line treatment will usually fall short to create a drug resistance. And this data suggests that it is actually a problem, especially in those underdeveloped nations where you see the US, UK, Germany, and all the other developed countries don't have this problem. Africa does, because usually it's because of lack of follow-up. There is no reason for with a lack of follow-up, the first line usually fails and there's a relapse, and usually these cases tend to go to a second line treatment, which becomes more complicated to cure afterwards. So there's a couple of preventive attempts that I thought were cool. So we see that there's preventive attempts for children. So this data just shows that children that have been exposed to TB actually have been treated with a greater frequency over the last few years. Then again, this data is inconclusive because it's such short term, and we have a lack of countries that we can show this for. But usually prevention is always a good idea. And then we can see that people living with HIV on preventative therapy, which basically will try to help and stop those people from developing TB at the point where they have HIV, has been boosted in most countries. So that's always a good sign, and hopefully they keep on doing this. And then the antiretroviral therapy is not really relevant to our TB case. This is mostly an HIV thing that most HIV people do, and it's good that it's been in a stable level, because usually this makes people live a longer and healthier life when they are HIV positive. So to wrap it up, after showing you all this data with the facts that I said before, I propose the following solutions. So usually what I did was put this into two categories: so prevention and action. So in prevention, I said reinforce anti-discrimination drugs. So I think that doing this will help stop the poverty cycle, so that people can actually get jobs if they're HIV positive, and maintain them if that is possible. Better reinforcing laws for better working conditions. So this probably most likely in underdeveloped nations will help reduce the chance of contracting the disease in the first place. And then providing support for HIV and TB detection programs in patients. So it's important to do both because they're so closely related. As right now, we have the BCG vaccine, which is what usually is used in underdeveloped nations to treat especially children. But this is very, very old, and we should probably get a new thing in order to help support but also we need to find and identify those people that actually have TB and then be able to treat them in the first place, because we one of the biggest problems that we have is that we don't even know who the people who have TB are in these underdeveloped nations. And then for the action part, invest in the creation of databases to record and follow up with HIV and TB's patients' treatments. So once again, it's very important to know who these people are, if they've taken treatment, and if they got better or not, because those are probably the three things that could solve easily this problem if we implement it now towards the future. But most countries don't have the infrastructure to do that and don't have the funding. Secondly, advocate for universal access to healthcare systems. So obviously, more access will mean better chance at prevention, and then we're going to have better coverage in that sense. And then invest in research. Like I mentioned, the BCG vaccine is pretty old. It seems like TB has caught up with the current research, so it seems like we need to make more research, more experimentation, more vaccines in order for us to kind of outplay the TB bacteria at this point in time. So I think these goals are very feasible. They're realistic for today's standards. They will be very helpful to solve problems in politics, labor, public health, and development, because this interferes with many of those things. It's killing many people, and it would be very, very beneficial in different parts. And we can then go on and get towards our coveted development and sustainability goals. So some of the assumptions, limitations, and future analysis that could be done, well, this is a very complex problem, and the solutions may be hard to implement and take time. Like I said, this is probably a simplification of the problem, because there are many issues that need to be noticed and taken care of. But public health policy will be can get better at doing this, even though it's difficult to keep a tab on. And then for the future, is the most important part is the third thing I said for action: research. Invest in research, because we need more efficient diagnostics. We need to know who the people are. We need new drugs. We need better vaccines. It seems like we're a little bit outdated in terms of basically pointing out who the people are and how to treat them. So hope you learned something. Thanks for letting me participate.